This patient is a 96-year-old male that had constipation for several months. On the workup we saw an old patient with a very distended abdomen, and on plain X-ray we could see signs of a total colonic obstruction. Immediately after the plain X-ray we did an enema with water-soluble contrast, so we could continue with endoscopy not having any disturbance of, for instance, barium contrast. And this enema shows a typical stricture looking like a colonic cancer in the splenic flexure or just anal to the splenic flexure. After identification of the tumor, a radiological mucosa marking just below the tumor was created by injecting 1 cc of lipiodol submucosal. Next, a Boston Scientific RX system ERCP catheter preloaded with a 450 cm long jaguar diameter 0035 was passed down the endoscope. The catheter passed through the tumor over the wire and high into the proximal distended colon. A water-soluble contrast was injected into the lumen above the tumor. The pushing and pulling motion of the catheter while simultaneously injecting the contrast enabled fluoroscopic visualization of the tumor stricture. Now we are completely sure how the tumor stricture looks like, how narrow it is. The stricture was measured as 4 cm in length, and it was decided to use a 9 cm stent to allow 2 to 2.5 cm of healthy lumen on each end of the stent upon deployment. The Wallflex enteral colonic stent was loaded onto the guide wire and placed down the colonoscope's working channel. The delivery system containing 3 radiopaque markers was advanced to set up the placement of the stent. The first marker on the end of the exterior tube was lined up 4 cm beyond the stricture in the proximal part of the colon. As the exterior tube is withdrawn during deployment, this marker travels down the catheter as the stent is released from the delivery system. The second marker is a post-deployment marker band which was lined up in the distal part of the colon after the stricture, and we usually seek to hold this marker fixed during deployment. The third marker is a deployment limit marker band that shows you the point at which the stent can still be reconstrained. Deployment continued very slowly, simultaneously pulling backwards on the system while also keeping the stent fixed to keep it from slipping upstream. As the exterior tube marker band reaches the deployment limit marker band, deployment accelerates and the stent is released from the catheter. The stent selected has a 22 mm diameter body and a 27 mm proximal flare with braided nitinol and looped ends to minimize migration while supporting optimized luminal patency. After stent deployment, there are some very important issues. You should wait for the stent to expand for some minutes and then remove the deployment system, but always keep the guide wire in. If you're not completely happy with the stent position, either it kinks or impacts above or below the stricture, you can fairly easily save the situation by adding a second stent. After the procedure, we decide if the decompression is okay. And if we feel comfortable and the patient is doing well, we allow the patient to drink freely for the first 24 hours and therefore also remove any nasogastric tubes. And then next day, if he's still comfortable, he will be allowed to eat normally, and then probably very short after discharge. The typical good stent should be able to go through the scope channel, so you can watch the deployment both under fluoroscopy and under endoscopic view. It should have good compatibility with, for instance, ERCP accessories, meaning especially wires. It has a high radiopaque capabilities. But the main point is that you should avoid dilatation, meaning a high proportion of the strictures should be fairly easy to push the stent system through over the wire. And Wallflex gives us that opportunity. It fits the needs for the majority of both cases for palliation and bridge to surgery.